Our final speaker will be Yajuan Si of the University of Michigan Institute for Social Research, presenting about her UO1 award this time, Statistical Adjustments of Sample Representation in Community-Level Estimates of COVID-19 Transmission and Immunity. Yajuan, I'll turn it over to you.
Thank you, Megan, and thanks everyone for a whole day of hard work and hard listening and thinking and staying here till the end. I want to briefly talk about the goal of my UO1. So my training is a statistician, like I mentioned, and a pilot grant. So this UO1 is essentially a computational development. At the end of the day, if possible, we would like to put this computational interface through SPSR. Then for all the data sources you guys have gathered, we can run our adjustment approaches to increase the population generalizability. So this is the goal for this UO1 and the SBE CCC consortium. But at the same time, we try to promote this as a surveillance system. Then CDC will implement that. So we want to put this as the weather forecasting device for CDC in terms of COVID infection prevalence estimation, as well as the immunity prevalence estimation. I'm sure you guys have heard a lot of positivity rate, but we want to get a measure that is a proxy randomly based measure. Our team is really a mixed group of individuals. So I'm a statistician and my research is on survey adjustment, probability and non-probability surveys. I do weighting almost on a daily basis. Andrew Gelman is a very famous statistician who will provide computational support to this UO1. Like I said, we want to build an interface to implement our approaches. Then Lynn is a clinician, a full-time physician who has the background on biology and clinical interpretation or the promotion of our work in the hospital implementation perspective. Then we have John Zenner, who is an epidemiologist. So this UO1 is an adventure for us too, and we were mainly motivated by the COVID testing. So in US, there is no random COVID testing at all. And this has never been done, and we don't think it will be done in the future because of the declining response rates. I mean, you guys had just saw the chat, so Sharon and John were talking about the response rates, which are unbelievably lower during COVID than pre-COVID period. And then the opt-in bias is very big. So UK has implemented a randomized survey to get the COVID prevalence estimate. But then ironically, they were so concerned about the selection bias, and they have implemented our approach in the end to adjust their randomly selected sample at the beginning. But the concern is the declining response rates. So we see that most of the databases are from the government released positivity rates or other resources, especially the vaccination rates, but those are not randomly selected sample cases. So our concern is that how can we have a measure that can be representative of the true COVID infection prevalence as well as the immunity level? So for the immunity level, that could be occurred through vaccine. And then when you get infected, you will also get immunity. So how can we capture both vaccine acquired and naturally acquired immunity? So those are the motivations of our UO1. Then we have 4 specific aims to achieve those. So we want to estimate the infection prevalence and naturally, as well as vaccine occurred immunity level on the population level, as well as subgroups, especially for those vulnerable subpopulations. We have done this in Indiana Hospital. So now we are gathering data from Michigan Medicine, Henry Ford System, Columbia Medicine, Medical Schools records, and Colorado. So our idea is that once we have the hospital test data, which are very cheap, and then they can run the data analysis through our interface, then we can generate community level estimates based on the zip codes they have provided of their patients' records. So this is the aim 1. Then for aim 2, because our data are from asymptomatic patients who have surgery appointments with the hospital, they do not represent the overall magnitudes of the COVID infection prevalence. So we want to examine the health disparities with respect to the symptoms. So asymptomatic versus symptomatic ratio is different across sociodemographics. So it's interesting that, or it's also a big concern, Black individuals tended to be more asymptomatic comparing to white. So this is not biologically related. So we want to explore the socio-determinants of this health disparity in terms of COVID symptoms. And then we will build this interface to demonstrate the heterogeneity in terms of the health disparity and the social determinants in the interface too. Then for aim 4, because our data from the hospital system, the key assumption is that the patients get their COVID test is because the surgery requirement, it has nothing to do with their potential outcomes. Actually, most of the patients are very surprised to see their positive results because they were asymptomatic. So we want to integrate these electronic health records with other COVID contextual data, such as the supplemental modules from the PSID and the HRS. So then essentially we can evaluate the selection bias of different data sources and see whether there is a way to harmonize all of them in a single framework. Then you can adjust for the selection or non-response bias for each survey. And then at the end of the day, including this interface, we want to generalize the results toward the whole nation. And like I said, these data are the hospital routine testing data. The key assumption is that they have surgery appointments and they are required to have the COVID test in the designated clinics of the particular hospital. And then some patients have their blood tests, then we can test their IgG, the immunity level. So since 2001 February, we can test the IgG protein that can tell you whether it's naturally occurred or it's vaccination occurred. Okay. So I mentioned the Mr. P when I introduced the pilot grant, but you don't need to worry about that because we will use the interface to run Mr. P. But the idea is to adjust for the sample representation. So our preliminary work has shown that the adjusted prevalence can predict the clinical burden. You can see they can run well with the emergency department visits. But if you look at the IgG prevalence biologically, once you get infected, that will add the margin to the curve of the IgG prevalence. But if you look at the vaccination rates, so for different subgroups, the vaccination rates are very low. That's why you keep seeing the promotion for you to get vaccinated. But actually, if you test the immunity level, most individuals already have the antibody already. So we wanted to emphasize this asymptomatic patients' positivity. So they don't know they were affected, but they already have the antibody. And to move forward, like I said, we have this big goal to put together this interface as a surveillance system. Through this consortium's effort, we really want to everybody to try our approach. Eventually, we hope CDC will buy it. Thank you.